Chapter 30 of the 2018 Clinical Practice Guidelines is on retinopathy. My name is Alice Chang, and I am recording this on behalf of the chapter authors Filiberto Altamare, Amin Karani, and Julie Lovshin. The key changes from this chapter included new information on the effectiveness of local intraocular pharmacological therapies in improving vision and reducing the level of diabetic retinopathy. The retinopathy checklist is as follows. Screening should occur on a regular basis. Onset and progression of retinopathy should be delayed with glycemic and blood pressure control, plus or minus the use of fibrate therapy. One should treat established disease with laser photocoagulation, intraocular injection of medications, or vitreoretinal surgery. The prevalence of diabetic retinopathy is shown here on this slide. Unfortunately, it remains the most common cause of blindness among working age individuals. Although these data are somewhat dated, you can see that the estimated prevalence of proliferative retinopathy is greatest in those living with type 1 diabetes at 23%. And then the next category would be type 2 diabetes on insulin at 14%. And then finally, only 3% in those with type 2 diabetes on non-insulin antihyperglycemics. Another form of diabetic retinopathy is, of course, macular edema. And the prevalence of macular edema is shown here as 11% in type 1 diabetes, 15% in type 2 diabetes on insulin, and 4% in type 2 diabetes on non-insulin therapies. One would hope that with the advances that we have made over the last number of decades, that a repeat of this type of analysis will show reductions in the prevalence of diabetic retinopathy. Now, retinopathy is associated with an increase in morbidity as well as mortality. And that is because visual loss itself is associated with increased falls, more hip fractures, a four-fold increase in mortality, and also early death in type 1 diabetes. And therefore, everything we can do to try to prevent the onset of retinopathy or to slow the progression of retinopathy if it already exists is certainly worthwhile. So what are the forms of retinopathy? There are three forms of retinopathy. The first is macular edema, second is non-proliferative and proliferative retinopathy, and the third type is retinal capillary closure. So macular edema represents diffuse or focal vascular leakage at the level of the macula, often related to ischemia of the retina. The other form of diabetic retinopathy, and perhaps the one that is best known by people, is either non-proliferative or proliferative retinopathy, which represents microvascular changes in the retina. In the earlier stages, it is considered non-proliferative, and what is seen are microaneurysms, intraretinal hemorrhage, vascular tortuosity, and vascular malformation. If allowed to progress further, the retinopathy can then become proliferative, which means that there is abnormal vessel growth into the vitreous itself, and usually those abnormal vessels are quite frail and friable, and those are the ones that tend to bleed. The third type of diabetic retinopathy that does not get discussed as often is retinal capillary closure, which is a form of vascular closure that is only detectable on retinal angiography. It is potentially blinding, and currently there are no known treatment options. So how often and when should we be screening for retinopathy? In type 1 diabetes, screening should occur starting at 5 years after diagnosis in all individuals over the age of 15. In type 2 diabetes, however, screening should occur at the time of diagnosis, And the rationale is that some of these individuals may have had diabetes for longer prior to diagnosis, and therefore some of those individuals may actually already have retinopathy at the point of diagnosis. Contrast this though with type 1 diabetes, where there is an absolute insulin deficiency, so therefore the likelihood of having had diabetes for a long time prior to diagnosis is actually quite low. How the screening should really occur with a healthcare professional who is expertise in eye exams. And the screening can occur either through stereoscopic color fundus photography with interpretation by a trained reader, or direct ophthalmoscopy or indirect slit lamp fundoscopy, but through a dilated pupil. The final option is digital fundus photography. Now, if retinopathy is found to be present, then it is important to establish an appropriate monitoring interval, which would usually be done by the eye care professional. Typically, the interval of monitoring would be 1 year or less. If sight-threatening retinopathy exists, then that of course must be treated by an eye care professional with either laser or pharmacological or surgical therapy. And then of course it is important to prevent progression of the retinopathy through glycemic control, blood pressure control, and lipid control where appropriate, and we will talk about this more later. And then of course one should screen for other diabetes complications, given that the presence of retinopathy would suggest that the patient is susceptible to other complications. However, if retinopathy is not present, then in the case of type 1 diabetes, the recommendation is for screening to occur on an annual basis. In type 2 diabetes, screening should occur every 1 to 2 years. And then of course, we want to prevent the development of retinopathy through good glycemic and blood pressure control, as well as lipid therapy where appropriate. And then of course, regular screening for other diabetes complications should also occur. The risk factors for progression of diabetic retinopathy includes those with a longer duration of diabetes, elevated A1C, hypertension or dyslipidemia, low hemoglobin level, pregnancy, particularly in type 1 diabetes, and that is likely related to the fact that pregnancy itself can worsen retinopathy, as well as aggressive, quick reductions in glycemia that we typically institute in pregnancy. Other risk factors include the presence of proteinuria and, of course, the presence of severe retinopathy itself. What we can do to try to delay the disease is provide good glycemic control, targeting an A1C less than or equal to 7%, and it's also been shown in individuals with type 2 diabetes that targeting less than or equal to 6.5% will also further reduce the risk of retinopathy. Blood pressure should also be targeted to less than 130/80. And finally, lipid-lowering therapy may be appropriate in certain individuals, and in fact, fibrates have been shown to decrease progression and may be considered. So why does the A1C target exist? Well, here are data from type 1 diabetes looking at the DCCT, which is the Diabetes Control and Complications Trial. In this study, individuals living with type 1 diabetes were randomized to more intensive glycemic control versus less intensive glycemic control and followed over time to determine what happened to complications. On the left-hand panel, you can see that more intensive glycemic control resulted in a 76% relative risk reduction in the primary development of retinopathy. On the right-hand panel, you can see that intensive glycemic control resulted in a 54% relative risk reduction in the progression of retinopathy. So what this tells us is that good glycemic control is effective in reducing the onset of retinopathy as well as reducing the progression of retinopathy. Now, from a blood pressure perspective, we have data in type 2 diabetes from the UK PBS. In the UKPDS study, they also had individuals with more intensive blood pressure control versus those with less intensive blood pressure control. And you can see that the darker black line is lower than that of the blue line, meaning that tighter blood pressure control did result in less microvascular complications. But of course, those microvascular complications were not just that of retinopathy. So if we take a closer look at retinopathy data from the UKPDS, it is fairly clear to see that the point estimates are all on the left side of unity, and a number of them are in fact statistically significant, showing again that better blood pressure control is helpful for reducing retinopathy. And then we have the ACCORD study. So the ACCORD study was a large randomized controlled trial of type 2 diabetes looking at the relevance of intensive glycemic control targeting less than 6.5% versus a higher level. But within the ACCORD study, there was also a section where they looked at lipid control with either statin therapy or statin plus fibrate. So when they looked at the sub-study of just ACCORD-I, in which patients actually had regular systematic examinations of the eyes, one could see that intensive glycemic control, as well as the combination of fenofibrate and simvastatin, were able to reduce the rate of progression of diabetic retinopathy in this older high-risk population. So ACCORD-I confirms the importance of glycemic control, but it also raised the question of whether fibrate on top of statin could also reduce diabetic retinopathy. And in fact, this was something that had been seen previously in the FIELD study, which looked at the use of fenofibrate on top of existing statin therapy from a cardiovascular perspective, but they also collected data on retinopathy, and there was interestingly a 30% reduction in retinopathy requiring laser amongst those taking fenofibrate. And therefore, it is recommended that fenofibrate could be considered to be added in individuals with retinopathy. Now, diabetic retinopathy can be effectively treated. Pan-retinal photocoagulation with laser therapy can be useful to reduce blindness by 90% in severe non-proliferative or proliferative retinopathy. Another option, which is gaining in popularity because of the evidence surrounding it, are local pharmacologic interventions which involve intraocular injections of VEGF antagonists. So VEGF is vascular endothelial growth factor. And as you know, retinopathy involves the growth of abnormal blood vessels. So therefore, if we could inhibit VEGF, one could imagine that there'd be benefit in the back of the eye in terms of new growth. And that is in fact what has been seen with these VEGF antagonists being able to improve vision. Finally, there is also the surgical option, which is vitrectomy. So sight-threatening retinopathy must be prevented with good blood glucose and blood pressure control, plus or minus fenofibrate, detected through regular screening, and treated with laser therapy, anti-VEGF medications, or vitrectomy in order to save vision. So the recommendations within this chapter are as follows. Recommendation 1. In individuals over the age of 15 with type 1 diabetes, screening and evaluation for retinopathy should be performed annually by an experienced vision care professional, ideally an optometrist or ophthalmologist, starting 5 years after the onset of diabetes. Recommendation number 2. Individuals with type 2 diabetes, screening and evaluation for diabetic retinopathy should be performed by an experienced vision care professional, i.e. optometrist or ophthalmologist, at the time of diagnosis of diabetes. The interval for follow-up assessment should be tailored to the severity of the retinopathy. In those with no or minimal retinopathy, The recommended interval is 1 to 2 years. Recommendation 3. Screening for diabetic retinopathy should be performed by an experienced vision care professional, such as an optometrist or ophthalmologist, either in person or through interpretation of retinal photographs taken through dilated pupils or undilated pupils with high-resolution ultra-wide field imaging. Recommendation 4. Results of eye examinations and the follow-up interval and plan should be clearly communicated to all members of the diabetes healthcare team to promote optimal care. Recommendation 5. To prevent the onset and delay the progression of diabetic retinopathy, people with diabetes should be treated to achieve optimal control of blood glucose and blood pressure. Recommendation 6. Though not recommended for cardiovascular disease prevention or treatment, fenofibrate, in addition to statin therapy, may be used in people with type 2 diabetes to slow the progression of established retinopathy. Recommendation 7. Individuals with sight-threatening diabetic retinopathy should be assessed by a qualified ophthalmologist and/or retina specialist. Pharmacological intervention, laser therapy, and/or vitrectomy may be used to manage the diabetic retinopathy. Recommendation 8. Visually disabled people should be referred for low vision evaluation and rehabilitation. So the key messages from the retinopathy chapter are as follows. Regular screening is important for early detection of treatable diabetic retinopathy. Screening intervals for diabetic retinopathy vary according to the individual's age and type of diabetes. Optimal glycemic control reduces the onset and progression of sight-threatening diabetic retinopathy. And finally, local intraocular pharmacological therapies have the potential to improve vision and reduce the level of retinopathy. The key messages for people living with diabetes are as follows. Diabetic retinopathy involves changes to retinal blood vessels that can cause them to bleed or leak fluid, distorting vision. With good glycemic control, regular eye exams, and early treatment, the risk of vision loss is reduced. Diabetic retinopathy often goes unnoticed until vision loss occurs. Therefore, people with diabetes should get a comprehensive dilated eye exam regularly. Discuss the recommended frequency with your diabetes healthcare team and experienced vision care professionals, optometrists or ophthalmologists. Finally, diabetic retinopathy can be treated with several therapies used alone or in combination. Thank you for your attention, and I encourage you to visit the guidelines.diabetes.ca website to get more information as well as to access the full document and interactive tools and other slides and videos. And of course, please remember to download the app from Google Play or the App Store. Thank you very much for your attention.